Hello everyone. My name is Li. I'm from China. Um, Today my presentation is about a paper report. The topic is approaches to managing epilepsy by Baby Chen and Joseph Serving from Mayo. An estimated 3.5 million people in the United States live with epilepsy. The burden of epilepsy is turned beyond the effect of seizures themselves to encompass significant negative impact on mental health, social, and financial well-being, and overall quality of life. Here we will discuss the current options for treatment of epilepsy, focusing on practical approaches for neurologists. Epilepsy is defined as the occurrence of two seizures more than 24 hours apart, or one seizure with supportive evidence that indicates increased risk of recurrent seizures. The supportive evidence such as MI, EEG abnormal. Current management options include anti-seizure medications, diary therapies, neuromodulation devices, surgical management. The main goal of anti-seizure therapy is to achieve seizure freedom with the lowest effective dosing of appropriate medications and or the least invasive method. Should one fail to achieve seizure freedom with ESM alone, other therapeutic options are available. There are currently more than 25 FDA-approved ESMs available in the United States for the management of epilepsy. Let's see the table. The first, for the generalized seizure, and isosaximide, special for absent seizure. T-type calcium blocker has long half-life of 30 to 60 hours, risk of headache in children. Felbamate inhibits GABA agonist NAFDA receptor, risk of aplastic anemia and or hepatic failure. Laxomand, sodium channel blocker, it has slow inactivation of sodium channel, dose-dependent PR interval prolongation. Lamotrigine, sodium channel blocker, risk of LSGS levels increased with wild-fruit, decreased with pregnancy. Levetiracetam bind SV2A, risk of psychiatric side effects, including suicidal ideations. Prorampanel antagonize NAPTA receptor, AMPA receptor. Risk of psychiatric side effects, including suicide and homicide ideations. Phenobacter inhibits GABA, potent P450 inducer, risk of osteoporosis, contraindicated in EIP. Phenytoin, sodium channel blocker, risk of ataxia, incoordination, nystagmus, osteoporosis. Promindo inhibits GABA, risk of osteoporosis, contraindicated in EIP. Topiramate, sodium channel blocker inhibits GABA, antagonize NAFDA receptor, risk of cognitive impairment, kidney stones, weight loss. Wild-fruit, T-type calcium blocker, sodium channel blocker inhibits GABA, risk of teratogenicity, hepatotoxicity, pancreatitis. Next is for the focal seizures. First, brivaracetam bind SV2A, higher affinity and selectivity for SV2A compared with levetiracetam. Carbamazepine, sodium channel blocker, risk of SGS in each patient with HLA-B 5002 allele. Oxcarbazepine, sodium channel blocker, risk of hypernatremia, exacerbate absence and myoclonic seizures. And for the next is escarbazepine, sodium channel blocker. It has slow inactivation of sodium channel. Felbamate, loxamine, lactarigine, levetiracetam, perampanel, and phenobarbital, phenytoin, topiramate, wild They can use in general seizures and focal seizures. Next, zonisamide, T-type channel blocker, sodium channel blocker, has long half-life of around 50 hours, not an enzyme-induced or inhibitor. And for some special syndromes such as LGS, DS, ES, and we can see the first is cannabidiol. For DS, LGS, enhanced GABA may modulate intracellular calcium, increase concentration of clobazam metabolite. Clobazam for LGS enhanced GABA, only adjunct therapy. Rare risk of SGS. Clonazepam for LGS enhanced GABA, approved use in absence seizures in patients that feel insulsamide. Felbamate for LGS, fenfluramine for DS, LGS, enhanced serotonin, risk of decreased appetite, while heart disease. Lamotrigine for LGS, remind for LGS through sodium channel blocker. Risk of shortening QT interval. Stiripentol for LGS enhanced GABA. Adjunct therapy to patient also taking clobazam. Topiramate for LGS. Rigabentin for ES enhanced GABA, risk of permanent visual field impairment. Several new ASMs, including stiripentol, fenfluramine, and cenobamate, received FDA approved over the past few years for the management of seizures. Stiripentol is approved as an adjunct therapy for patients with DS who are aged 26 months or weight over 15 pounds and take clobazam. Its main mechanism is likely through enhanced GABA and or indirectly increasing clobazam concentration via P450 inhibition. Fenfluramine is approved for patients aged over 2 years with DS or LGS, originally recognized as an appetite suppressant. Currently, the anti-seizure effect of from increasing serotonin concentration in the case of fenfluramine remains unclear. The last one is cenobamate is approved for patients aged over 18 years with focal onset epilepsy. It acts as a sodium channel blocker with preference for the present sodium current as well as a GABA agent. Studies have shown excellent efficiency in patients with refractory focal seizures with monthly seizure reduction in up to 56% and the seizure freedom rate of up to 28%. Each EMs with its own unique advantages and disadvantages. The prescribing physician must consider efficacy against specific seizure types or epilepsy syndromes, side effect profiles, patient comorbidities, available formulations, and pharmacokinetic properties. Should a patient require multiple ESMs, consideration should be taken to minimize drug-to-drug interactions. Most ESMs are metabolized by the liver and carry risk of interactions when taken together. Special consideration should be given to prescribing medicines for women who are pregnant or plan to become pregnant, and for elderly patients. All women of pregnancy age should be consulted on ESM side effect on the fetus. The risk of teratogenicity varies between ages. Wyproot, carbamazepine, isatuximide, phenobarbital, phenytoin, and topiramate carry the highest risk of fetal malformation. Additionally, many ESM can decrease in concentration during pregnancy and therefore increase the risk of breakthrough seizure. It is beneficial to check ESM levels earlier in pregnancy and every transmitter. Free levels may be more advantageous compared with total levels, particularly for ESM that are less protein-bound, and as total plasma protein decreased throughout the course of a pregnancy. In the elderly population, common body illness reduced protein binding, decreased renal clearance, and slower metabolism also increase risk of ESM toxicity. Due to high prevalence of comorbidity in this population, special attention should be paid to drug interactions and adverse effects. For those who continue to have seizures on appropriate monotherapy and a therapeutic dose, the next step is to try an alternative monotherapy or a dual therapy with synergistic effect while minimizing synergistic toxicity. Approximately 30% of people with epilepsies do not achieve seizure freedom with 1 to 2 ESMs. Those who fail to achieve sustained seizure freedom after adequately trying two appropriately chosen ESMs, either as monotherapy or in combination, have drug-resistant epilepsy. These patients should be considered for alternative methods of seizure control, including diuretic therapy, epilepsy surgery, and neuromodulation. Ketogenic diet, medium-chain triglyceride diet, modified Atkins diet, and low glycemic index diet are therapeutic options for patients with epilepsy, though the current evidence is stronger in the pediatric compared with the adult population. In patients with drug-resistant epilepsy who have a single seizure focus that can be safely resected, surgery provides the best option for seizure freedom, achieved in an estimate 65 to 73% of patients with temporal lobe seizures, in 27 to 60% of those with extratemporal lobe seizures. Anterotemporal lobectomy can help achieve seizure freedom in most patients with mesotemporal onset epilepsy. Removal of symptomatic lesions such as cavernous indolescent tumors is associated with a higher rate of seizure freedom. Seizure outcomes are typically less successful in non-temporal lobe epilepsies and may carry more risk in terms of permanent deficit due to eloquent context and risk. There is increasing interest in the use of minimally invasive surgical techniques. One such technique is laser interstitial thermal therapy, which has become widely adopted for mesotemporal sclerosis, hyperthermic hematomas, and small cortical dysplasias. A small series have shown LITT in MTS to be familiar to those from open ELT with less neurocognitive risk. In patients who have seizure onset full cell that to surgical insection or disconnection, neuromodulation is a available option. 3 devices are approved for the management of refractory focal epilepsies, VNS, DBS, and RNS. These devices do not eliminate the seizure focus, but have been shown to significantly reduce seizure frequency in long-term treatment. The RNS is a closed-loop device that can deliver electrical stimulation in response to detecting seizure activity. Although VNS and DBS closed-loop models are being developed and studied, the traditional VNS and DBS devices use open-loop systems, where electrical stimulation is delivered based on a preset schedule irrespective of ongoing electrophysiological activity in the brain. Looking ahead, with so many available therapeutic options, the goals and the challenges of anti-seizure therapy will be to customize and tailor to the individual patient based on genetics and earlier classification of a patient electroclinical syndrome, assessing who is likely to be drug resistant, so surgical options can be presented earlier to the patient. Okay, that's all. Thank you.